Thank you, chairpersons, and thanks, Manikantan and Kiran and the Light team for having me. Uh, Heart failure is a great masquerader, basically because it shares many of the symptoms and maybe sometimes the signs of many other associated diseases. And there was too many classification, backward, forward, systolic, diastolic. So finally, we have a universal definition of the heart failure, which has rather simplified into heart failure with reduced ejection fraction, HFrEF, and on the other hand, heart failure with preserved ejection fraction, HFpEF. And of course, in the intermediate group, you have the mildly reduced one. So we're going to talk about heart failure with preserved ejection fraction today. The problem with HFpEF has been we have been obsessed with heart failure means reduced ejection fraction. That the fault came with the definition. If you can see, heart failure develops when the heart, because of an abnormal cardiac function, fails to pump. So we were giving more and more importance to that terminology, fails to pump, rather than the second sentence. It's also when it is associated with an elevated filling pressure. So heart failure with preserved ejection fraction, it's an important entity mainly because over the years, if you could see the spectra of heart failure, you could see that there are more and more instances of HFpEF happening world across. And unfortunately, the survival rate of heart failure with preserved is similar to heart failure with reduced ejection fraction, which is much worse than many of the cancers. More than 50% mortality at the end of 5 years. Our own data from the Trivandrum registry saw almost 64 or 65% mortality at the end of 5 years. This was the Indian scenario I was talking based on the Trivandrum heart failure registry. And you could see that when it comes to heart failure hospitalization, which is again one of the real menace in managing heart failure, it's near similar. And we also know that every heart failure hospitalization increases the mortality. Our understanding of HFpEF has completely changed from this particular volume pressure graph. We were all thinking at one time that heart failure, HFpEF, is a matter of a diastolic dysfunction. But we have changed from that concept. We know that every important organ are involved in HFpEF, and there are lots of pathophysiological mechanisms happening. The time will not permit me to go through the entire thing, except that it is not just a diastolic dysfunction alone which is happening in heart failure with preserved ejection fraction. There are very many other factors coming into play, and that leads on to heart failure with preserved ejection fraction. So it's a very busy slide. I will not again confuse you with so many things, except to understand that it has a complex pathobiology, and there is even incompetence of very many other associated functions, a chronotropic incompetence and an autonomic dysfunction, microvascular dysfunction. So the spectrum has radically changed, and the understanding is much better. I will just briefly pass through a 74-year-old gentleman with increasing fatigue and breathlessness. So he had trouble in sleeping at night. He had an MI, of course, hypertensive, and these were the clinical data. One should understand that the symptoms and signs of heart failure, whether it is reduced ejection fraction or preserved ejection fraction, are near similar. And the symptoms like fatigue, breathlessness can happen even in non-heart failure situation like COPD or asthma. So knowing that there is an entity of HFpEF will won half the battle. So knowing is important. Then, of course, we will be helped by investigations. And see that the electrocardiogram and chest X-ray may help you. Generally, in HFpEF, we expect a near normal heart size with pulmonary hypertension. The ECG may not be of much help. The enzyme biomarker, BNP, and the pro-BNP and other markers will be generally elevated in every heart failure. But mind you, a normal BNP does not exclude heart failure with preserved ejection fraction. That is again one of the confusion that you should know. Essentially, you make a differentiation whether it is a reduced ejection fraction or a preserved ejection fraction by doing an echo. And in this gentleman, the ejection fraction seems to be okay, 55%. And the other diastolic indices, I will not again confuse you with so many other indices. There are a lot of echo-based indices of diastolic dysfunction coming up every day, except to say that there are features of diastolic dysfunction. So the principles of diagnosis is you listen to the story, have a basic examination. Confirmation is by if the biomarkers are elevated, fine. But confirmation basically is based on echocardiography. So try to find out whether it's a heart failure with reduced ejection fraction or the ejection fraction is preserved. And then you have to investigate further what is the underlying cause. See, it's a heterogeneous condition. Heart failure with preserved ejection fraction could be caused by very many diseases. So that is one of the problems why it is underdiagnosed, why it is undertreated. Basically, the diagnosis is a stage process. So you assess the clinically, then initial diagnostic workup, then a detailed workup. Sometimes, apart from the clinical examination, ECG, chest X-ray, biomarker, and echo, you may have to do, because when you do the echo, you may presume that the diastolic functions look normal. Then you may be compelled to do an exercise response. They call it diastolic stress testing, find out whether there is an elevation in the LVEDP, the end diastolic pressure, or the LA volume indices. These will all help you if your basal echo was showing a normal diastolic function. So you should not stop there. So you should be doing an exercise response, an exercise echo, and find out that. We know the difficulties in diagnosis of HFpEF, unlike the HFrEF. So there are some scoring systems, just like Binu told you about the scoring and assessing how to assess the severity of a SCS. You have some the scoring system called the HFpEF scoring. These are the scoring system, and you could see that now if the probability of heart failure with preserved ejection fraction increases with the increasing score. If you have a score of 6, there is a 90% chance that this gentleman could be having a HFpEF. So this scoring system may help you, but then it is always good to have this sort of scoring system in your ICU or outpatient department. There are also, apart from the scoring system which help the physicians to identify HFpEF, there are also algorithms how to approach when you diagnose HFpEF, how to go further. The European Society and the Heart Failure Association of America has given us, if you have a breathless patient, you have a clinical assessment, basic investigation, echocardiogram, then assess the HFpEF score. If necessary, do the diastolic stress testing, and very rarely, even though an invasive testing is the gold standard of diagnosis of heart failure with preserved ejection fraction, in maybe about 98% of the time, it's very seldom, very extremely rare instances only, you have to do a hemodynamic testing and diagnose HFpEF. I mean, in JAPI, a couple of months ago, we have also had a consensus guideline published by the Indian group, which again give you an idea what you should be doing in this when your diagnosis is in doubt. What should be your best approach? How to go about in a patient with breathlessness, and if the diagnosis is HFpEF, what is the best way of protection? As we were talking, echo is the most important investigation. There are so many indices, as I was talking earlier. But basic, the mitral valve Doppler echoes, then the tissue Doppler, the strain rate imaging. Again, I have no intentions to bore you with a lot of things on echo, because none of us, even I'm not good in strain rate imaging. But there's a tremendous improvement happening in the echo assessment of diastolic dysfunction, and all these things are important in finding out which are the subgroup of HFpEF patient. Also, there is an great importance given to left atrial function. See, it is not the left ventricular function alone. We are talking about the right ventricle. Importance of elevated pulmonary artery pressure in diastolic dysfunction. Here again, the importance of LA volume indexes, left atrial failure, assessing left atrial strain rate. Left atrium is becoming an important organ in diastolic heart failures. It also will help us in differentiating, even prognosticating by echo, which are the subgroups of HFpEF patient who will do badly. All of us know the comorbidities in heart failure, in diastolic heart failure, the importance of it. Just a word on, even though possibly it is not my role, Jabir is going to talk maybe at length on HFrEF management, not on HFpEF. We have nothing to manage HFpEF till about 3 or 4 years ago, except maybe decongestants and maybe MRA. But the last 2 years has seen a tremendous changes happening in the management. The ARNI, which has a class 2B recommendation, and SGLT2 inhibitors, which I'm sure right now it is class 2A recommendation. But all the data are coming up showing that don't look at EF. SGLT2 inhibitors are the best drug in subsets of heart failure, whether it is HFrEF, one of the important foundational drugs, whether it is HFrEF or HFpEF. The important thing is every physician cardiologist should know about utilizing these drugs in every heart failure patient. So, ladies and gentlemen, HFpEF is a very common condition. The mortality is equal to HFrEF. There is a gross shift in understanding the disease. Echocardiogram becomes one of the important, and every day we are getting newer and newer information on the echo parameters. Management options are limited, but ARNI and SGLT2 and ARNI are the important drugs apart from the decongestants that we use. Adopting these important guideline-directed treatment at the earliest will improve the prognosis of patient with HFpEF. Thank you for your kind attention.
Thank you, sir. Now, do you think we are missing a lot of diagnosis of heart failure and preserved ejection fraction? Because in the practical front, whenever a physician sees an echocardiography report showing good LV systolic function, then it's taken for granted that the cardiac function is okay. That is, I think, the most important thing that we miss. Nobody critically, now we need a critical analysis of the diastolic function, not the E by A alone. There are multiple parameters, or as told, like whether the LA is enlarged, whether there is a left ventricular hypertrophy, whether the LV filling pressure identified by E prime is high. And a significant number of patients with unidentified pulmonary hypertension would be a diastolic dysfunction. What's your
Absolutely true. See, even our own data, where you could see that the Trivandrum registry there was only some 18 to 20% prevalence of HFpEF, which is not true. Possibly the prediction is that by in another 5 years, 65% of all heart failure will be HFpEF. As Jabir said, I think every clinician should spend time on, just like EF, more than 50%. Oh, this is not heart failure. That is what the concept of HFpEF. If you have it, then half the battle is won. Then you can go through the diastolic dysfunction parameters, Every day it is improving on, and then give the guideline directed treatment appropriate.
Especially a patient with unexplained dyspnea, if there is no other things to explain the dyspnea, especially if they don't have a significant pulmonary disease to account the dyspnea. A patient with unexplained pulmonary hypertension, especially these people with these multiple comorbidities which are explained. So these are two subgroup of patients where it could be diastolic dysfunction, and also we have to look for any reversible cause for the diastolic dysfunction. So it's going to, in the Western world, it's 65 or 70% heart failure with preserved ejection fraction. Our data doesn't show that much, probably because of the fact we are missing
You
the
are
diagnosis.
underdiagnosing.
Any questions or comments from the audience? Sir, yes, sir. Manjunath, sir.
As Jabar has rightly pointed out, patients coming with exertional breathlessness should have a diastolic stress test done. You need not do a very complex testing for diastolic stress test. You can record the parameters. If the parameters are normal, then you can, by a diastolic stress test, you can bring out the diastolic dysfunction. This can be done by just raising both the lower limbs passively for about 3 to 5 minutes and re-record E ratio, E prime ratio, and pulmonary arterial pressure from tricuspid regurgitation. These three parameters are enough. You need not go for all these LA strain and LA,
Right.
all those parameters. Only three are enough. And if that also is negative, then all probability the woman is not having, or the person is not having any diastolic dysfunction. So this should become a part of the routine. In our lab, we always do it. Every patient with breathlessness, if the diastolic parameters are normal, we do a diastolic stress test by raising both the lower limbs passively for 3 to 5 minutes.
There are many physicians who does echo these days. So pay just also attention to the diastolic functions of the heart. Just don't be stopped short with when somebody has symptoms of heart failure. If normal, don't say that this is not heart failure. Thank you.